Medical and Surgical History of the War of the Rebellion, United States Surgeon General's Office, published 1875. Volume 2, Chapter 9. Of the approximately 29,000 amputations performed on the Union side during the war, approximately 71% of the patients survived. 71%. The Surgeon General's office presented this figure with pride. It was considered a remarkable achievement. 1 in 4 men who went under the saw did not come back from it. And amputation was not the worst outcome. Amputation was frequently the attempt to prevent the worst outcome. This is the story of what happened between the bullet entering the body and the decision to remove the limb. And what happened after. It is the summer of 1862. You are a surgeon attached to a Union field hospital somewhere in Northern Virginia. Your training was 3 years at a medical college. Lectures, anatomical demonstrations, perhaps a handful of supervised procedures. Before this war, you had performed surgery fewer than a dozen times. In the next 48 hours following the Battle of Antietam, you will perform surgery more times than you can count. The field hospital is a barn. The operating table is a door laid across 2 sawhorses. The light comes through gaps in the boards and from lanterns hung on nails. Outside, in the September heat, the wounded are arriving faster than anyone can process them.
The men who can walk have walked. The men who cannot walk have been carried, dragged, or left until someone came back for them. Some have been lying in the field for hours, some longer. The Ambulance Corps, formalized by Jonathan Letterman just weeks before this battle, is the reason any of them arrive at the barn at all. Before Letterman's system, wounded men were sometimes recovered from the field 2 or 3 days after the fighting ended. In summer heat, without water, without any protection from the sun. Letterman changed this. Dedicated stretcher bearers, designated ambulance wagons, a triage point close to the battlefield that separated the walking wounded from those who needed immediate surgery from those who could not be saved by anything available. The men arriving at your barn have been through that first filter. They are here because someone determined there was something you could do. The weapon that has put most of them here is the Minié Ball. A conical lead projectile, half an inch in diameter, fired from a rifled musket at a velocity sufficient to cover 1/4 of a mile in approximately 1 second. When it strikes bone, and it strikes bone frequently because the human body is not large and its skeleton is not peripheral, it does not pass cleanly through. It tumbles. It fragments. It carries with it whatever it passed through on entry. Fabric, soil, the surface of the skin, deep into the wound channel. The shattered bone, the displaced tissue, the contamination from outside the body. These are now packed together inside a wound that the body has no template for surviving. The surgeons of 1862 understood none of the biology of what followed. Germ theory, the understanding that infection is caused by microscopic organisms, was available in the literature. Louis Pasteur had published his foundational work in 1859. Joseph Lister would not apply it to surgical antisepsis until 1865. In the barn in Virginia in 1862, the gap between what science knew and what the man holding the saw knew was the distance between life and death for the man on the door. The first decision is triage. You assess the wound. If the ball has struck soft tissue only,
muscle, flesh, without hitting the bone, the prognosis is reasonable. Clean the wound as well as you can. Pack it. Wait. If the bone is involved, the calculation changes entirely. A shattered femur, the large bone of the upper leg, cannot be splinted into healing. The fragments are too numerous, too displaced, too contaminated. Left in place, they will begin to rot inside the body. The infection that follows kills in days. The alternative is amputation. Removal of the limb above the point of injury while the patient is still strong enough to survive the procedure, before the infection has spread, before the fever has set in, before the body has begun to fail. Speed is not a measure of indifference. It is a clinical strategy. An experienced Civil War surgeon could perform an above-the-knee amputation in under 4 minutes. The critics who called them Sawbones, who accused the surgeons of removing limbs that could have been saved, were generally observers who had not spent time in the wards 3 weeks after the battle, watching what happened to the men whose limbs had been preserved. If you want to understand how military medicine, and medicine generally, moved from this barn to something recognizable as modern practice, this channel follows that thread across multiple episodes. Subscribe and hit the bell so you don't miss where this story goes next. Now, back to the operating table. The anesthetic is chloroform, administered on a cloth held over the nose and mouth. It works. By 1862, chloroform anesthesia is standard practice in both Union and Confederate field hospitals. This was not always the case. Ether had been introduced into surgical practice in 1846, just 16 years before this battle. Before that, the options were alcohol, opium in whatever form was available, and the speed of the surgeon's hands. The introduction of anesthesia transformed what surgery could attempt. Procedures that had been impossible because no conscious patient could hold still long enough were suddenly within reach. It also, paradoxically, made the infection problem worse. When surgery was limited by the patient's ability to endure it, operations were short and superficial. With anesthesia, surgeons could work longer, deeper, more extensively. More time inside the body. More opportunity for contamination. The image of the Civil War soldier biting a bullet while surgeons cut is largely a myth. Most surgical patients were unconscious. Most did not feel the saw. What they felt, if they survived, began afterward. The wound is closed. The stump is dressed with bandages that have been used before, washed but not sterilized, because sterilization as a concept does not yet exist in surgical practice. The instruments you used have been wiped on a cloth between patients. Some surgeons rinsed them in water. Most did not. This is not negligence by the standards of 1862. The dominant theory of infection at this time is miasma, the belief that disease is caused by bad air, by the emanation of rotting organic matter. The smell of a field hospital was understood as a symptom of the disease risk, not its cause. And so the wards were ventilated, windows opened, floors washed with lime. The instruments, the direct vector of bacterial transfer from one open wound to another, remained unaddressed. Hospital gangrene. It is not the same as gas gangrene, the deep tissue infection associated with battlefield wounds. Hospital gangrene was a ward disease. It spread from patient to patient, carried on dressings, on the hands of attendants, on the instruments moved between beds. The wards themselves contributed. Buildings converted for hospital use, barns, churches, private homes, courthouse halls, were not designed for the concentration of open wounds they were now asked to manage. Poor drainage. Inadequate light. Floors that absorbed blood and fluid and could not be cleaned to any meaningful standard. Beds close enough together that the air between them, already believed to be the disease vector, circulated freely from one patient to the next. The nurses and medical attendants who worked these wards did so under conditions that would be unrecognizable to anyone trained today. 12-hour shifts. No protective equipment. Physical contact with dozens of infected wounds in the course of a single day, and then the same hands, wiped on an apron, moving to the next patient. Hospital gangrene began as a small spot on the wound surface, gray, slightly depressed, with a distinctive foul odor. Within 24 hours, it could spread several centimeters. Within 48, it could consume the entire stump. The treatment was to cut again, to excise the infected tissue, to remove more of the limb, to attempt to stay ahead of the spread. Some men underwent 3 or 4 procedures in the weeks following the initial amputation, each one carrying the same risks as the first, and each one performed with the same unsterilized instruments. The Union Army recorded approximately 16,000 cases of hospital gangrene during the war. The mortality rate for those cases was approximately 45%. The surgeons who treated these men were not indifferent to their suffering. The medical literature of the period documents genuine attempts to understand why some wards had higher rates than others, why some wounds healed cleanly while identical wounds in the next bed did not. The answer was in front of them. In the hands that moved between beds, in the sponges used to clean multiple wounds, in the probes inserted into wound channels to locate bullet fragments. Probes that were not washed between patients because washing them between patients was not part of any protocol that existed. Ignaz Semmelweis had proven in 1847 that hand washing reduced mortality in obstetric wards from roughly 10% to under 2%. He could not explain why it worked, because the bacterial mechanism had not yet been established, and the medical establishment largely rejected his findings. He died in an asylum in 1865. The same year, Lister began his antiseptic experiments. What changed after the Civil War was not immediate. Lister's antiseptic method, using carbolic acid to sterilize instruments, dressings, and the surgical field, was published in 1867. It was adopted slowly, unevenly, and with significant resistance from surgeons who had built careers on the methods the war had validated. But the war itself had created something that mattered: data. The medical and surgical history of the War of the Rebellion, 6 volumes, published between 1870 and 1888, was the most comprehensive medical data set ever assembled to that point in human history. Every wound, every procedure, every outcome. Categorized, tabulated, analyzed. It was used by researchers for decades. It informed the development of triage protocols still in use in modified form today. It established, statistically, which surgical approaches produced better outcomes, even before anyone understood the biological reasons why.
The barn in Virginia was also a laboratory. The surgeons working in it did not know that, but the data they generated outlasted the war by more than a century. The primary sources for this episode include the medical and surgical history of the War of the Rebellion, available in digitized form through the United States National Library of Medicine. The case studies of hospital gangrene are documented in Volume 2, Part 3. The surgical mortality statistics come from the same source, cross-referenced with Shauna Devine's Learning from the Wounded, published by the University of North Carolina Press in 2014. The Semmelweis data is from his own published work, Etiology, Concept, and Prophylaxis of Childbed Fever, 1861. A note on the Sawbones' reputation. The historical record consistently shows that the surgeons who performed the most amputations had among the best survival rates in their wards. The nickname was applied in contempt. The data suggests it was undeserved. Here is the detail I keep returning to. After the war, the United States Army Medical Museum in Washington put on public display a collection of bones, femurs, tibias, humeri, showing the characteristic shattering patterns of Minié Ball injuries. Thousands of specimens, labeled, cataloged, mounted in cases. Visitors came to see them. They were considered educational, a record of what had happened, preserved so that future surgeons would understand what they were dealing with. The collection still exists. It is held at the National Museum of Health and Medicine in Silver Spring, Maryland. You can visit it. 400,000 men died in the American Civil War from disease and wounds. The bones of some of them are in a museum, still teaching. If this is the kind of history you want more of, the version that doesn't stop at the battle, but follows the wound to the ward and beyond, subscribe to The Past Restored. The next episode takes you to London in 1854, where a doctor with a map and a removed pump handle changed how the world understood disease. Click the video on your screen. See you in the next archive.